Hi, Sean Collins here on tutorial 6. Here we're going to talk about obstructive pulmonary disease. In particular, the signs during activity that a person with obstructive lung disease has a disease-specific impairment as the cause of their endurance limitation. So we've made it quite a distance now. We are here at tutorial 6. And we continue to be in the meat of the algorithm. If you recall, the meat of this algorithm is that question about whether or not endurance is limited due to disease-specific impairments. And we have established that on the no arm of this decision, of this question, are any normal cardiopulmonary responses to a workload. Even if they cannot sustain the workload, if there's a normal cardiopulmonary response, it is most likely indicative of a non-disease specific impairment, or it's likely that you could answer no to the question, is endurance limited due to disease specific impairments? So we are today talking about the yes arm of this question, and we're talking about it specifically for COPD, chronic obstructive pulmonary disease. We've talked about it for heart failure. Now, just like heart failure, I have to tell you that having COPD does not in and of itself warrant that there is a disease-specific impairment for to their endurance limitation. I will say, however, that people seem to be able to live with more severe COPD than with more severe heart failure. So, at any given moment in time, I would make the hypothesis that there are more people living at home with obstructive pulmonary disease that is severe enough that they have a disease-specific impairment to their endurance. I wouldn't make that claim for heart failure, but I would feel comfortable making that claim for COPD. In fact, if you happen to have someone on your caseload that is diagnosed as severe or end-stage COPD, I would bet very, very highly that any workload above baseline is a disease-specific impairment to their workload. If you have a patient with COPD that is on CPAP, so here's a CPAP or BiPAP. CPAP and BiPAP are positive airway pressure support that are provided to people with COPD because they actually can never reach homeostasis of their CO2 levels. So what happens in someone with COPD in the very late stages is that their CO2 levels rise, and then they go on CPAP and BiPAP and they drop, and then they rise, and then they go on CPAP and BiPAP and they drop. Now when they drop, they're usually still greater than normal. They're usually still in the 45 to 50 millimeters of mercury partial pressure of CO2, and when they rise, they're at levels that you or I would probably go into a coma if they achieved those levels. They can rise up into the 60 to 65 range. But what we're looking at here is a variable that usually is homeostatic. CO2 should stay around 40 millimeters of mercury. This is a homeostatic variable. It's a homeostatic variable that we do a lot of things to keep homeostatic. We increase blood flow to get it out of the muscles and get it to the lungs. We increase ventilation to get it out of the lungs, which allows it to come out of the blood. So we have variables that change: heart rate, stroke volume, cardiac output, respiratory rate, tidal volume, ventilation, specifically, but not only, but specifically in response to CO2, to get it out, so that it doesn't change tremendously from its normal resting level. That is true homeostasis. Now, in people who have a resting inability, you could basically say that an individual with COPD who was on CPAP or BiPAP specifically for their COPD doesn't even have the endurance to exist at rest. And we know, it's logically true, it's entailed, that they therefore do not have the endurance. They have a disease-specific impairment for any workload. Now, there's a caveat here. The caveat is that you may have patients who have COPD and are on CPAP or BiPAP because they have sleep apnea. And that is a very different scenario. My guess is that you would be able to tell the difference based upon how the individual is breathing when you go to see them. The person who is on it for sleep apnea is most likely not going to be on oxygen, whereas the person who has COPD and is on CPAP and BiPAP because of their COPD, they are most definitely going to be on oxygen. And the person who is on CPAP and BiPAP for severe or end-stage COPD is also going to have a very difficult time communicating with you, because talking is taking time away from their breathing. So that's the first thing to say. And from my meetings with you all, I've gotten the impression that tends to be the majority of people with COPD that you see. So let's just say that accounts for 80%. We're now talking maybe about the other 20% that you don't know the answer to this question for. The other 20% that you're trying to figure out the answer to this question. So the other 20%, how should they respond to activity? Respiratory rate should increase, and it should plateau with stable workloads. Tidal volume should increase. So increase, plateau with workloads. Increase, plateau with workloads. Tidal volume should also do that. But it's difficult to tell. In other words, you don't actually measure tidal volume. So what you're really going to be looking at for tidal volume is the chest wall. And chest wall excursion should increase with workloads. If the individual starts to have decreases in chest wall excursion, that is a sign that they have a ventilatory limitation to their workload. So ventilatory limitation to their workload, decreases in chest wall excursion. Now, by a decrease in chest wall excursion, I'm talking about the diameter of the chest when someone is fully exhaled as compared to the diameter of the chest when they're fully inhaled. And this is usually about 2.5 to 4 centimeters. Now, if they start at 2.5 and they decrease to 1 centimeter, that is an indication that they have had a reduction in chest wall excursion. You measure this with a tape measure, and you measure it at the level of the xiphoid process. That would be the most straightforward way to do these measurements. So you have them exhale all the air they can, and then you have them increase. Now, what is the reason for someone to have a decrease in chest wall excursion during activity? It's something called dynamic hyperinflation. What happens with dynamic hyperinflation? This is going to be time, and this is going to be volume of air. Someone is breathing in, and then they're breathing out, and then they're breathing in, and then they're breathing out. The number of breaths is their respiratory rate. The volume of their breaths is their tidal volume. The respiratory rate times the tidal volume equals their overall ventilation. Ventilation must increase with activity, and therefore with activity we breathe in more and we breathe more frequently. Now, one of the things we do is we breathe out more than we tend to breathe in. As we increase our ventilation, we tend to exhale more air. With COPD, that process is impaired. As they increase the rate, they can't expire as much air, and they start to stack their breaths, and they dynamically hyperinflate. This is over and above the hyperinflation they have all the time because of their disease process. And when that happens, there's a reduction in their chest wall excursion that stays around for a while. This is another variable that actually wouldn't be bad to test when you get to someone's home and have them do pursed-lip breathing to see if it changes and they have more excursion, so that you can have an idea of where this person is at baseline, what they can improve to, and how bad they get in their chest wall excursion. So this is all related to ventilatory impairments. Now, another indication of ventilatory impairment would be the reliance on accessory muscles, and these kind of cohere with one another. That if people have a reliance on the accessory muscles at rest, they most likely have reduced chest wall excursion. What happens is that with hyperinflation, we get decreased chest wall excursion. We get a flattened diaphragm. I can't spell it. And those two factors require the accessory muscles. So by seeing that there's a use of accessory muscles, we are basically seeing the consequences of the hyperinflation. So if somebody starts without using their accessory muscles and they progress to needing to use them, then chances are they had a reduction in chest wall excursion, they had a flattening of their diaphragm, making it less effective, and you are now looking at the consequences of that ventilatory impairment. In addition to ventilatory impairments, people can get respiratory impairments. Now, the reason I saved this for last in this tutorial is that this is the most basic of all the obvious signs of an impairment that is disease-specific. You know that during activity, whether the workload is increasing or whether the workload is staying the same, SpO2 should stay the same. So a respiratory impairment is most easily identified as a drop in the SpO2. So if SpO2 drops, and I would say drops by more than 5%, then you're looking at a respiratory impairment. Now, there's one thing I want to say about that. So I'm saying that if SpO2 drops by more than, or let's say greater than or equal to 5%, we have a respiratory disease-specific impairment. impairment for that workload. If SpO2 stays constant with increased supplemental O2 required, you also are looking at a respiratory disease-specific impairment. In other words, it's not just that the SpO2 drops, it's that if SpO2 is held constant because of increased supplemental oxygen, and that increased supplemental oxygen is required, then this is another way to classify someone as having, of answering yes to the question, is endurance limited due to a disease-specific impairment? What is a disease-specific impairment? It is a respiratory impairment because of their obstructive lung disease. Thank you.